Good morning, everybody. Thanks for letting me join the Assembly General of the European Medical Association. My name is Daniele Arces. I'm an intensive care specialist working cross site between London and Brussels. I'm sharing here an experience mostly developed in UK during the first wave of COVID-19 pandemic and how this experience could be translated in the work of general practitioners. My involvement with the COVID pandemic has been quite brutal. Back in March this year, I was asked to step back in the role of clinical lead for intensive care service after less than a month and after handing the role to a colleague. Unfortunately, this colleague got COVID pneumonia quite at the beginning of the pandemic, and it fell on me to carry on the emergency expansion of our service at an unprecedented level. This was quite a challenge because expanding the service to almost three times its capacity in a super short amount of time required a lot of flexibility, collaboration, and effort. While the level of change was unprecedented, luckily enough, the very nature of intensive care services is the ability of reacting rapidly to more or less unknown dangerous situation without knowing how long it will last and with a very uncertain outcome. Still, this was unprecedented. All the aspects of a severe pandemic were there. The diffusion was rapid, with acceleration in numbers in patients seeking medical help as I had never seen in 20 years of medical career. Most of the patients were in severe respiratory failure, requiring being put in a pharmacological coma, intubated and ventilated, the most life-threatening of all conditions. The number of such patients just doubled in the space of a week. One of the hospitals closest to ours had one horrible night where 17 patients had to be intubated in one night. In normal times, that hospital would not see more than one or two patients requiring an intubation in one night. Intensive care specialists had to be rushed from other hospitals to help. Also, at the same time, our staff numbers got stretched by people falling sick, just as it happened to my clinical lead, or being unable to expose themselves because of advanced age and comorbidities. Our group of consultants shrunk from 9 to 4 at some point. Basically, this was the perfect storm. Unsurprisingly, we saw a hell of a lot of people dying. Here is the curve of deaths from all causes in UK as compared to two other European countries. All the various activities of the healthcare system were concentrated in one single effort, that of reducing the rise of the infection curve as this drawing easily catches. While intensive care services are characterized by extreme flexibility within a specific niche of the whole of the healthcare services, the general practitioner finds himself or herself at the very center of the system. More, the GP is the main conduit between population and various systems, acting in coordination with hospitals, administrative and healthcare bodies, as well as community services. However, at the beginning of the pandemic, they found themselves caught on the back foot. Large majority of those who developed the worst form of pneumonia associated with the coronavirus were frail and elderly, often in care homes, and those were patients very complex, which once developed the illness were extremely difficult to manage. The shift to remote working resulted in inconsistent support for those patients, which was compounded by inadequate personal protective equipment and disorganized testing of staff and residents. The predicaments of the GPs were largely taken as a fait accompli, with the biggest efforts of the various governments were directed to hospital care. Enormous resources were directed to support the expansion of hospital beds, with temporary, albeit largely underused hospitals created in some of the biggest cities. This is an intensive care ventilator whose rushed procurement became one of the main activities in countries like the UK, which has a chronic short supply of such a highly specialized equipment. Also, the recovery phase from the pandemic saw the biggest efforts directed to other issues, as the health emergency appeared to improve the economic recovery, dominated news and both people and government's attention. Here is the UK Chancellor or Secretary of State for Economic Affairs in a publicity stunt to promote a government scheme back in August meant to attract customers in the hospitality sector. Some experts have postulated that the scheme was one of the factors at the base of second wave in UK. Once the second wave kicked in, the other big investment from various governments, the test and trace system, simply collapsed. The pandemic arrived at a moment of pre-existing weaknesses for the primary care structure, at least in the UK. To give just some examples, while flu pandemic protocols are largely present in UK hospitals, as they are key part of hospital governance, such protocols were often absent, scarce, or outdated in primary care. GPs found themselves in a situation where no clear guidelines were available to decide how to manage a large, rapid change in healthcare needs within their patient population, in a situation where even the traditional medical visit was not possible because of the risk of virus transmission. More, there is a huge problem with staff numbers within the whole of the NHS, and in primary care specifically. Across the UK, the number of GPs relative to the size of the population has fallen in a sustained way for the first time since the 1960s. So, the modern GP have to juggle an increasingly complex scenarios of labyrinthine public bodies, aging population, and social as well as health-related issues, also with increased workload because of dwindling numbers of colleagues. This scenario is often characterized by slow pace, a degree of resistance to changes as dependent by a number of external factors like commissioners or other regulatory bodies, while burdened by heavy bureaucracy. In this context, a rapid and sudden change in pace and complexity of work like we would see in intensive care and emergency service would be difficult to manage. We are now in the middle of a second wave, when only some of the previous problems have been taken care of. While we have a better knowledge of the disease from a clinical standpoint, we still have not acquired and incorporated essential changes for the general management of the pandemic, whether they are cultural or more operational ones. In addition, GPs, like all other healthcare professionals, are suffering from fatigue and stress related disease. The reality is that the introduction of emergency culture has long been advocated for GPs. WHO member states have repeatedly affirmed their commitment to developing their primary care systems with a view to training up community based health professionals who are able to provide care across the spectrum of prevention, preparedness, response, and recovery. As the front door of the health system, primary care professionals should be involved in planning and action for health emergency risk management. Also, WONCA, the global professional body for family medicine, has actively championed the ways in which primary care can be supported to deliver care during population emergency. More recently, in Australia, where the nature of the territory makes GPs more likely to be first responders to medical emergency, local administrations have included GPs in their emergency protocols and successfully spread the culture of emergency preparedness. To acquire such a culture, it would be necessary first to get familiar with basic elements of emergency and disaster planning. This means understanding, first of all, the principles underpinning it. These principles cover the various aspects of a coordinated, effective response to an event which is likely to happen rapidly and brutally. They are meant to be the fundament of every preparation plan and highlight the concepts of coordination, communication, flexibility, and feasibility. Amongst the principles, preparedness was the one more in short supply at the start of the pandemic. A lack of preparedness was one of the reasons primary care, with already the burden of their pre-existing deficits, suffered badly. A prepared system would have firstly identified in advance where the biggest difficulties could arise within a pandemic. For primary care, this would mean mostly the frail, complex patients, either at home or institutionalized. For these special patients, it could be envisaged a rapid way to increase the provision of monitoring of their health status with an intensity that can be provided by telemonitoring, in addition to scores that predict potential adverse outcomes. Undoubtedly, this means that a higher, rapidly increasing workload could suddenly burden the single GP. For this reason, close coordination with other GPs would be advisable, including agreement to cross-cover the patient population in order to react to inhomogeneous surges of infection in the community. The current structure of primary care in UK is such that networks at local level already exist. While those networks have been key to give practical help, there wasn't a structured and uniform response to the new challenge. Clarity with roles and coordination from higher structures should be part of the preparation. Therefore, it's key to recognize the role of the national bodies in supporting the frontline staff. Professional bodies such as the Royal College of GPs in the UK have taken an active role in communication with both the public and the professionals. It's then a matter of organization at local level to have various single aspects of response to emergency ready. This could be things as practical as having enough PPE stocked or readily accessible, or triage areas already envisaged, in order to be prepared to react to sudden increase in number of potentially difficult to handle consultations or visits. The sticky problem of reacting to maxi emergency is to have enough people to handle them. While it is not possible to create professionals from one day to another, it is possible to identify tasks that could be in emergency allocated to alternative staff. In the case of GP, this could be staff with the ability of doing triage, for example, or clerks able to flex to manage multiple calls and a higher volume of patients. These could be voluntary or part-time staff which has been trained professionally to handle specific tasks in case of need, and for which occasional deployment in live or simulated scenarios could build the minimum skills and confidence required. Also, staff with alternative roles but used to flexibility and communication could be invaluable in case of redeployment. During redeployment of non-intensive care staff in critical care, I cannot forget how physiotherapists outperformed operating theatre staff. Physiotherapists are used to adapt their action to the different needs of complex patients, also using the communication skills to engage them, while operating theatre stars are brilliant but necessarily meticulously focused on specific aspects with little or no adaptations. And once the emergency staff has been identified, a strategy for rapid alert, redeployment, and task allocation should be envisaged. The same forethought for organizing the structure and the staff should crucially be used for having the extra equipment available and ready to deploy. It will usually take also to identify the member or members of staff tasked with looking after the equipment aspect. Never like in emergency and maxi emergencies, it's crucial to have the availability of relevant digital technologies. Telemonitoring and telesurveillance, health data transmissions, treatment follow-up in live mode, while not unusual outside of emergency context, are essentials in the management of higher than usual number of patients. Wearables are quickly moving from devices that can tell you how many steps you've walked to products that can accurately tell you about your health. The FDA, the American Food and Drug Administration, recently approved the Apple Watch Series 4 and 5, both of which have a rudimentary electrocardiograph on board to take electrocardiograms for diagnostic purposes. Also, the higher level of coordination between GPs and health agencies, as well as fellow peers, requires familiarization and handling of telecommunication, such as virtual meetings, regular catch up, both formal and informal ones. Finally, the emergency context moves the GP away from what has been the traditional role of a mostly lone worker with little or no team to manage. This is not much anymore. Leadership skills have long been advocated for healthcare professionals. Moreover, response to emergencies implies working in close coordination with other professionals and often in a position of leader. While leadership skills are advisable in whatever situation involving a team of professionals, they are much more required in emergency ones, where the team is required to act more rapidly, in a more cohesive manner, more efficiently. This is even more true where newly emergency staff are required to integrate a team needing sudden expansion to cope with emergency. What I have spoken about so far doesn't want to be, and definitely it is not an exhaustive list of what should be done to have GPs better prepared to front emergencies such as a pandemic. It wants to be a suggestion to instigate a change, looking for innovative ways to change the way we work. The GPMB, the Global Preparedness Monitoring Board, an independent group of experts who analyzes the world preparedness to major challenges, wrote a report back in 2019. The report said we were not prepared to face emergencies like a pandemic. In their second report in September this year, the experts had to sadly confirm their previous prevision and highlight that a lack of action will always make futile whatever commitment. Preparing for emergencies, while it's obvious to say it matters, should also become an actual reality. And in failure in doing this, it will mean failing ensuring other needless deaths like that of these friends who coincidentally died of COVID while working in emergency system. Thanks for your attention.